invite Dr. Shaloo. She will be now building up actually how to examine a case of proptosis, what all things to be kept in mind, and then we'll go to the next talk of how to manage those tumors.
Thank you, Dr. Ruchi, for including me in your course. It's not showing there. So orbital disorders, as we have already seen in Dr. Seema's talk, they are quite challenging in diagnosing, and so thus a proper systematic and thorough comprehensive evaluation is needed. Before we start the evaluation, this is not moving. Excuse me, not moving. So proptosis is defined as the abnormal protrusion of an eyeball beyond the boundaries of an orbit. It can be following an isolated orbital pathology, or it can be extension from the adjacent structures, or like sinus or cranial cavity, or maybe a manifestation of a systemic disease. Exophthalmos, which was earlier synonymous to proptosis, was now reserved for prominence of eyeballs secondary to thyroid eye disease. So any forward bulging beyond 21 millimeter or measurement of more than 21 millimeter or asymmetry of 2 millimeter is considered as proptosis. Some of the other terminologies which one should be aware of is dystopia, which is a displacement of eyeball in coronal plane due to the extracorneal mass. And exorbitism is used when there is a shallow orbit or reduced orbital cavity. And pseudoproptosis, it mimics proptosis. There is no forward bulging, and it's seen in the conditions like ophthalmos, high myope, retraction of the lid, and the contralateral in ophthalmos. So coming to clinical evaluation, it requires a thorough meticulous history taking and systemic and ophthalmic examination, so that we can narrow down our differentials and order our investigation and plan our management. Coming to history, what all points are important. The age of the patient, it should be noted. What was the course and duration, progression of the disease, any increase following any Valsalva maneuver, is it associated with any visual disturbance, diplopia, any pain, redness, is there any associated neurosensory loss. So why age is important? Because there are specific disease for the specific age groups. Like in children, we can have dermoid, benign lesion like dermoid or hemangioma, and malignancies like rhabdo or gliomas. In middle age, more common are thyroid eye disease like ramal gland mass or NSOI, and in elderly we can have malignancies. So it's important to note the course and duration, because if it's acute presentation, we know we are dealing with any infection, inflammation, or there can be acute hemorrhage in case like in lymphangiomas, where after the respiratory tract infection we can have a sudden bleed. Or it's a chronic, we can have thyroid eye disease, dermoid, or any tumor. So course of the disease is very important to note, and if whether it's within the hours or it's taking a months or years for proptosis. Progression should be noted, whether it's progressive disease, is static or intermittent. Intermittent one are usually seen in cases like lymphangioma or varices. And is it associated with pain? Severe pain is usually seen in cases of infection or inflammation or vascular lesion like high flow CCF or malignancies, and dull boring pain can be seen when there is a bone erosion. So all these points are very important, and we should ask in history. It is also important to ask for any bruit, any history of trauma, relevant systemic disease, and note down any past medical, surgical, or family history. So coming to examination, it's important to have a thorough systemic and ophthalmic examination. Note down any facial asymmetry. Whenever we are doing the systemic examination, it is the lymph nodes should be palpable. We should palpate the lymph nodes, and detailed cranial nerve examination should be carried out. And as simple as cutaneous examination, which can be done in OPD. So presence of cafe alert spot indicates that is towards the neurofibromatosis. Coming to ophthalmic examination, it's important to note down the best corrective visual acuity, pupil assessment, Both direct and consensual reaction should be noted, and any discrepancy in size requires a thorough evaluation. IOP measurement, especially in restrictive pathology, we know that when we measure the IOP in upcase, there is a rise, like in thyroid eye disease. And interior segment examination includes the examination of conjunctiva. If we see a salmon patch-like lesion, it indicates lymphoma. This lobulated vascular lesion suggests varices. Elevated episcleral vessel indicates there is a raised venous pressure, so you suspect the vascular pathology. Iris should be examined, like lesion like Lisch nodules indicates neurofibromatosis. So all the examination will help us in narrowing down differentials. And detailed fundus examination is required to see any pressure signs, if there is any papilledema, the presence of optociliary shunt vessels indicates meningioma. Oculomotility assessment should be done in all 9 gazes. It helps in noting diagnosing is whether it's restrictive pathology, paralytic, or it's a mechanical motility restriction. So one can do the force reduction test to differentiate between the restrictive and paralytic pathology, and uncover and PBCT can be done for noting down the documentation of the eye alignment and for documenting the diplopia charting and binocular vision. Color vision is done to if there is an abnormality, it indicates the optic nerve compression and also visual field. So all these things, and depending upon what are you dealing with, these are the things you should keep in mind and do in your documentations. Coming to examination of proptosis, it is important to know whether it's unilateral or bilateral. So there are specific diseases which are present bilaterally. So it should be noted whether the displacement is axial or non-axial. And if there is an axial, we know we are dealing with the intraconal lesion like thyroid eye disease or cavernous malformation, schwannoma, or gliomas. Non-axial proptosis is basically the eyeball is pushed in the opposite direction of the mass. If it's an upward displacement, we are dealing with the lesion in the inferior space. If it's downward, we know it's a superior mass, and down and out is a medial, supromedial mass, and down and in we have the supralateral mass. So all these points are important to know. The measurement of proptosis should be done in all 3 directions. If it's a subtle, you are not very sure, you can do a Navier method or worm's eye view, which helps in note down the if there is any proptosis. So axial proptosis is measured using a we can have Lewis or Hertel being the gold standard. But however, if you don't have anything handy, you can use a simple scale, put it at a lateral orbital rim, and measure the distance to the corneal apex, and you will note down if you will know that it's a proptosis or not. So for Hertels, it's important certain points to note down the bar reading, remove the parallax, so that you have a proper reading. The horizontal displacement can be done by using a scale, put a mark at the root of the nose and measure the distance at the medial limbus. And if there is a vertical dystopia, then use the 2 scale methods. So it's important to note down any, you can have a non-specific changes like edema, erythema, which may be indicating a infection, inflammation, or a malignancy. So these all points should be noted down. It's important to put a finger, palpate between the orbital rim and the eyeball, and if you feel any mass, indicates the mass in the anterior orbit. And if you have a mass in the around the orbital margin, palpate it, see the temperature, surface, is it mobile or not, is fixed to the underlying skin, overlying skin or underlying bone, whether it's reducible or compressible. Lesions like hemangioma, schwannoma are compressible. However, if it's non-reducible, it means it's a solid mass behind. And you can perform the Valsalva maneuver whenever you're suspecting a vascular lesion. This is an example of viruses. So it shows the increase in proptosis. Auscultate any pulsation if you feel. It can be a vascular pulsation or transmitted in cases of neurofibroma due to the defect in the sphenoid wing. So all these points are required depending upon what you are dealing with. So remember, whenever you have a patient of proptosis, remember 9 P's, whether the pain, progression, proptosis, palpate, pulsation, see the pupil, PBCT, perception of color vision, and see if there are any periorbital changes. And the 10th one is also important, the past medical or surgical history. So remember, whenever you're taking a patient of proptosis, in history and physical examination, these P's are important. And then have a narrow down your differential, orders the investigation, lab investigation and imaging, and then you can go ahead and plan and the management of these patients. Thank you.
Thank you, Dr.